I have no conflict of interest to disclose. I believe that in the field of vascular liver disease, there are 4 areas which have undergone significant progresses in the last couple of years and which I would like to discuss with you. Unfortunately, for the sake of keeping my time, I will be able only to discuss the first 2, congenital extrahepatic portosystemic shunt, the so-called Abernethy malformation, and the portal vein thrombosis in cirrhosis. The 2 other issues, you will find the discussion in the syllabus, which will be published I hope, in a few weeks in Liver International, and concerns recanalization of the thrombosed portal vein by various means, and the use of direct oral anticoagulants. But I must say that I sacrificed this aspect because although data are accruing, it's still difficult to draw solid conclusions. So to begin with the extrahepatic portosystemic shunt, they are regarded as congenital when they are found in infant or in association with severe vascular malformations, or in children or adults in the absence of any significant liver disease or portal hypertension. There is virtually a myriad of possible congenital extrahepatic portosystemic shunts, at least 1 per patient, 1 type per patient. But it is possible to group them together with regard to pathophysiology. And you have here the first type, which is the persistence of the ductus venosus. The portal vein, the intrahepatic portal vein, is preserved, but there is an extrahepatic shunt. The other types may consist of end-to-side type of shunts, where the main portal vein joins the inferior vena cava, or side-to-side shunts, where there is a shunting vessel, either between the portal vein and the inferior vena cava, or between the radicals of the portal veins and the inferior vena cava. This type has in the past been equated to agenesis of the portal vein, or congenital absence of the portal vein. And these ones with atresia or hypoplasia of the portal vein. But actually, when you are able to occlude, for example, with a balloon, the shunt and perform an angiography, in most cases, it is possible to show, to demonstrate that there is a remaining intrahepatic portal venous system, sometimes fully normal and sometimes thread-like. The reason why I'm discussing this entity today is that in the last few months appeared a study in hepatology by the Vascular Liver Disease Interest Group, which collected in 23 referral centers 66 cases in mostly adult patients. You can see that the median age was 30 years. You can see here the main complications that were recorded: hepatic encephalopathy, pulmonary arterial hypertension, hepatopulmonary syndrome, classical complications of vascular liver diseases, hepatocellular carcinoma, adenoma, benign nodules, again, another type of complication, which is classical in vascular liver disease. You can see also that there was no complication. The patients were fully asymptomatic. The condition was discovered fortuitously in about 1/3 of patients. The fact that this condition can be completely asymptomatic suggests that there might be an overestimation of the clinically obvious complications, because you need an occasion, an opportunity to make the examinations that will disclose the shunt. But there is also a possibility for those complications that have a long infraclinical course, that there is an underdiagnosis because you need special tests to disclose the condition before the clinical manifestations have appeared. And this is illustrated, you can see here the median age at the occurrence of the complications, early adulthood in this series, but with a wide range of ages and the possibility to disclose the condition in patients after the 4th, 5th, 6th, or even 7th decade. So we have to consider this condition, whatever the age of the subject. This is illustrated by these cumulative incidence curves for hepatic encephalopathy here, for any complication here. Here, a scale of age in years. Age is the same as the duration of the condition because it is a congenital malformation. You can see that for encephalopathy, there is a steady rise of the cumulative incidence of encephalopathy until the 3rd decade, then a plateau, and then again a rise, which is likely related to the interaction between the aging brain and the infraclinical condition. But you can see also that when you take into account all the possible complications, then the cumulative incidence is steadily increasing all along the life of the affected patients. There are some interesting data regarding the distribution of gender. You can see that for these complications that are related to the vascular changes, there is an almost balanced distribution. However, for these conditions which are related to the proliferation of hepatocytes, there is a marked difference. HCC was almost exclusively observed in males and adenomas exclusively in females. This is interesting from a pathogenetic or carcinogenetic point of view, but it is also very interesting from a clinical point of view, because when you are facing an hepatocellular tumor in a male, it is most likely that it will be an HCC, whereas in a female, there is a possibility, the probability is that it will be a benign tumor. Actually, 30% of the female patients in this series developed an adenoma during the follow-up. This survey allowed to touch on shunt closure, the effects of shunt closure, which is believed to be the source of all the problems. Among 19 patients with hepatic encephalopathy, 4 closures, 4 improvements. Pulmonary arterial hypertension, 3 closures, 2 resolution. Hepatopulmonary syndrome, 2 closures, 2 resolution, no complications of closure. This is very important because there is no publication bias. It's a series of consecutive cases, so it is quite convincing. Then adenomas, just 1 case, no conclusion. But there were 5 patients that underwent preemptive or prophylactic closure of the shunt without any obvious complications, and there was no complication related to the closure or related to the conclusion in the follow-up. And therefore, Valdig concluded that once the diagnosis is confirmed, consider prophylactic shunt closure, which is a very strong message. And personally, I was not enthusiastic with this, but I think I am now convinced by the data presented in this retrospective survey. Otherwise, we should investigate further complications and use the specific tests that allow to disclose the infraclinical forms of the disease and eventually come to shunt closure if we don't adopt a prophylactic policy. Let's turn now to the complications, some aspects of portal vein thrombosis in patients with cirrhosis. And I think that the 3 fields which have undergone, again, some advances in the last years has been the possibility to predict the development of portal vein thrombosis in such patients by measuring portal vein flow velocity. Then the impact of the use of non-specific adrenergic blockers and the risk of developing portal vein thrombosis. And finally, what is the clinical relevance, practical relevance of the entity of transient portal vein thrombosis? So you are well aware that it is generally admitted that there are two consequences of cirrhosis that can contribute to the development of portal vein thrombosis. The first one is the procoagulant state, and the second one is a decreased portal vein velocity. I will not discuss this, but I would like to review some data relating the decreased portal vein velocity with the subsequent development of portal vein thrombosis. And actually, there are 5 longitudinal studies that support the view that a decreased portal vein velocity is a favoring factor for the development of portal vein thrombosis. There are prospective studies, there are retrospective studies, but still, some of the studies give a very good prediction capacity. Look at these 2 longitudinal studies, a very high risk of portal vein thrombosis development when the velocity is below 15 centimeters per second, but only 2% when it is above, and there are similar results in retrospective case control studies. Here, a 4th study with less convincing results. Look, the portal vein blood flow velocity had an area under the curve for the prediction of portal vein thrombosis, which was only 0.71. It was less than the predictive capacity of the Child-Pugh score, and we know that the severity of liver disease is a very strong predictor of the subsequent development of portal vein thrombosis. In addition, there are very good data from retrospective or prospective studies that do not support a role, an independent role, of the decreased portal venous flow velocity. So what is the reason, the explanation for such discrepancies? First of all, of course, we are speaking of measuring the velocity with Doppler ultrasound with a huge variability intra-observer and inter-observer. So the reproducibility is an issue, but I don't think that it isn't the explanation for all the discrepancies. I think there is a strong risk of a strong factor for the discrepant result, which is related to the interaction of velocity with the severity of liver disease. You all know that when the disease progresses, the velocity decreases. This has been very well demonstrated. But there is also something which is remarkable, that these studies that did not show any independent value of decreased portal vein velocity were all performed in patients in a very good condition, whereas these studies that supported a relationship were performed in patients with a more advanced liver disease. And so there is a possibility that the action of the decreased velocity is mostly taking place in the patients with an advanced liver disease, not in the patients with a well-preserved liver function. There is also a possibility of an interaction with independent factors, obesity, NASH, the treatment of the cause of the use of non-specific beta blockers, which might interact and which were not taken into account in all of these studies. Therefore, in conclusion, for this small part, I believe that there is indeed a tight relationship between portal vein blood flow velocity and the severity of liver disease, so that the independent impact of each factor is extremely difficult to evaluate. We need very large sample of patients, which we do not have studied yet. But I believe that the decreased velocity is likely to contribute, particularly in patients with advanced liver disease, and there is a very strong biological plausibility for that. But, very importantly, portal vein flow velocity is not discriminant enough to serve as a trigger point for therapy, be it anticoagulation or TIPS insertion of any kind or any kind of intervention. Non-specific beta adrenergic blockers. There is obviously an interaction between portal blood flow velocity and non-specific beta adrenergic blockers. They decrease portal blood flow, they decrease portal venous velocity. It has been well demonstrated. And so there was an interest in doing a meta-analysis, a systematic review with meta-analysis of all the studies that included this factor in their analysis. And you can see that indeed this meta-analysis disclosed that the use of non-specific beta blockers was associated with a risk of portal vein thrombosis that was increased by almost 5-fold. But there was some heterogeneity among the studies. And in fact, it is difficult to interpret because beta blockers are given to patients with large varices, and we know very well that large varices are an independent risk factor for the development of portal vein thrombosis, even after adjustment for the severity of liver disease. But there are some multivariate analyses combining beta blockers and esophageal varices. In this first study, the two factors proved to be independent, to have an independent impact on the risk of portal vein thrombosis. But in this study performed in Portugal, indeed, there was an association between the presence of large esophageal varices and the risk of portal vein thrombosis, and the association disappeared after adjustment for the use of non-specific beta blockers. But conversely, as there was an association between non-specific beta blockers and the advent of portal vein thrombosis, but this did not disappear after adjustment for portal venous blood flow velocity or for the decrease in heart rate. So that here, non-specific beta blockers appear to have a proper and independent effect on the risk of developing portal vein thrombosis without acting through a decreased portal velocity or any other hemodynamic effect. But you can see that after adjustment for esophageal varices, the association was not significant. I think we have to take this data with much caution. Look, only 19 events in this study, 11 events in this study. It's not enough to perform a meta-analysis, a multivariate analysis. So it is just a matter to have some concern regarding the role of beta blockers, but that require further studies. And so there is a tight relationship between non-specific beta adrenergic blockade and esophageal varices, so that the independent impact of each factor is difficult to evaluate. But the mechanism, if any, remains elusive. It's not just decreasing portal vein flow velocity. Other mechanisms can be discussed, and you will find them in the manuscript. And additional data are obviously needed before management is modified. I want to remind you that non-specific beta blockers increase survival and decrease the rate of bleeding, whatever their effect on portal vein thrombosis, and we should not forget this. Then transient portal vein thrombosis. This entity is illustrated here. A patient entering a program for the screening of hepatocellular carcinoma, a marginal thrombus found here in February 2017, but 2 months later, the examination repeated, the thrombus has disappeared. Actually, when we take into account all the patients with portal vein thrombosis and cirrhosis, the vast majority only have partial thrombosis, not a complete occlusion. And in 1/3 of them, the thrombus is transient, will not be found in a subsequent examination. And then this raises two questions. The first one is, could it be that the causes and the risk factors for partial or transient portal vein thrombosis differ from those of complete permanent obstruction? And similarly, could it be that the prognostic meaning or the actual consequences of partial or transient portal vein thrombosis differ from those of complete obstruction, complete permanent obstruction? To discuss this, we must have a clear definition of what is transient portal vein thrombosis, even if it is very common. I think we can agree that it is a condition where a portal vein thrombus resolves. Once this is said, the devil is entering into the details. Because which imaging procedure to be sensitive enough and specific enough? Which schedule for re-evaluation? 2 weeks, 1 month, 3 months, 6 months? Again, to be specific and sensitive. What about regression without resolution? How do we qualify this? And what to do with the recurrence? There was a transient portal vein thrombosis, but it recurs. Isn't it permanent thrombosis? Again, to make it short, and I have presented the data for discussion in the manuscript, I think that for the imaging procedure, we all agree that it is CT or MR, with an advantage to MR just because of safety. The schedule for evaluation, probably 3 monthly. Regression without resolution, the answer is in morphometry, which can be done, has been done, and is a very good means to cope with this problem. For the recurrence, I think that at the present time, we have to neglect this entity. And so I think we have a more clear definition on what a transient portal vein thrombosis is. But what is important is the meaning, the clinical meaning. And so what is the impact of spontaneous recanalization, which characterizes transient portal vein thrombosis? We have no data survey dedicated to this issue, but we have at hand some longitudinal studies that indirectly allow to answer. We have 3 longitudinal studies on de novo portal vein thrombosis and 1 longitudinal studies on the impact of changes in thrombus size, and none of these studies disclose any independent impact of the modification of the thrombus or the occurrence of the thrombus on the outcome and the prognosis. This is spontaneous. But we now treat an increasing proportion of our patients with anticoagulation, and there has been many studies looking at the impact of recanalization in patients receiving anticoagulation. And what is suggested, I insist, just suggested by the available data, is an improved event-free survival, improved liver function test, decreased mortality. But much work remains to be done to really ensure that these are real effects, independent effects. And actually, I would like to illustrate this point by these impressive data from Marco Sanzolo and a large Italian consortium. You can see here the incidence, the incidence of death in patients with Child-Pugh BC without recanalization, and here in Child-Pugh BC with recanalization, all on anticoagulation. A huge difference. And this difference appears to be larger than in patients with Child A cirrhosis without recanalization, and here in Child A cirrhosis with recanalization. But you see that when you perform a multivariate analysis, there was no impact of anticoagulation and no impact of recanalization. But still, it could be that recanalization in a patient receiving anticoagulation is a very good prognostic marker on treatment. And to conclude, I would like to remind you this really seminal paper, 25 years ago, when Ian Wanless described the intrahepatic thrombosis in the portal venous system in patients that had explanted liver because of severe liver disease and liver transplantation. And then it could be that a marginal thrombus, transient thrombus, on anticoagulation could be an index to say, yes, anticoagulation did have an effect either on the intrahepatic activation of coagulation or to prevent the development of the thrombosis, full thrombosis of the extrahepatic portal venous system. And so to conclude, diagnosis of a congenital extrahepatic portosystemic shunt and its closure should be liberally considered. It's not a matter of age, it can still be congenital. Slowing of portal blood flow parallels progression of cirrhosis and development of portal vein thrombosis. Still, no threshold of velocity triggering anticoagulation therapy or TIPS insertion has yet been established. Non-specific beta blockers may contribute to portal venous thrombosis, but direct evidence and the exact mechanisms are still to be provided. And at present, no change in current practice are warranted. And finally, transient portal vein thrombosis is most common in cirrhosis, as you all know, but its role as an indicator for subsequent extrahepatic extension or as a factor for aggravating liver disease is certainly most interesting and requires further studies. Thank you.